Hi. Do you think you should do every patient, you should go below the knee, maybe you need CTA in order to prevent, to avoid renal failure or excess of contrast dye? Or do you have to select the patient you need to do that CTA?
So I think that's a good question. I think it depends on your patient and your clinical situation. So a lot of times a patient will come in and they have normal renal function. I may go to an MRA if I can, because I know that shouldn't affect their renal function. We know one thing about gadolinium, it won't affect the renal function. If you have bad renal function, it can lead to NSF, and that's why we don't do it in that patient population. But if I have a patient that has borderline renal function, and I say, okay, I can probably get my angiogram with 100 cc's, I'll save my 100 cc's for my angiogram, I get a good duplex map, a good non-invasive, and use that going forward. If a lot of times in the outpatient, I'll have a little bit more time, I'll stagger. I'll get a CTA or an MRA and then plan the procedure that way.
So Tino, on the same lines, you have a fantastic non-invasive lab. Why can't you do all of that with just duplex?
I just don't think we get, even though the duplex map and the Doppler map are excellent and they're really helpful, I just think we get a lot more answers in terms of the sizing. I think we just get a lot more information for some reason. I think you bring up a good question. A lot of patients I go based on my non-invasive forward. I think if I can get a CTA, I just think that it adds, at least in our hands and when we're discussing these cases, it gives us a little bit more information. Are we going to go from the right or left? Are we going to go antegrade up and over? What's the quality of that SFA? Is it something that we need to stage? Is it something that's going to be a two-stage procedure? But I think you're right. If you have a good non-invasive, and that's why I think that's the critical step. I wouldn't go forward without that.
Thank you. Go ahead.
Quick question. One thing is I absolutely agree with the MRA because we definitely have patients where we see no outflow in the foot. Even on the angiogram, we sit there waiting with the DSA forever, but on the MRA that usually I have to discuss with radiology to tell them exactly what we're looking for, we can find the pedal vessels. But my question actually is, do any of you use perfusion imaging, like the SPY Elite, for example, when directing reperfusion or what to do with the foot?
Yeah, I have some experience with that. I used that technology before. I found it challenging, to be honest with you, because many of these patients with ulcers have inflammation. And when you use the endocyanide green and you inject, it usually kind of clusters in the area of inflammation. So in my experience, when I used it, it was just the wound would light up. And there is other things that they tell you can look at, like ingress and egress and those kind of stuff. This technology was originally developed for bypass. It didn't really do that well and has now moved to reconstructive surgery for the gut and the breast. In the last 5 to 7 years, the company, actually I was involved with them trying to evaluate it for the leg. I just have found it difficult interpreting, some of the data that you get from the images. I don't know if anybody else on the panel has used it.
I totally agree with you. We tried it for almost 6 months in our center too, and one of the other bigger issues was inability to get it approved. Right. So there's no CPT code for it, and those type of things are also an issue too with that.
And our issue was how practical it was to get done. I mean, I was looking for something that I can do, someone's coming to my office, and that key of assessment of that patient a week or 2 weeks afterwards, and had to do an injection, it had to be in a central vein, am I gonna get a central line in these patients, am I gonna try to get a big caliber IV? I mean, not only was it not reimbursed, but just the setup. It was I was hated for several months.
Even the machine is huge, the device is huge, so there were some challenges.
Can I ask, Brian, you talked a little bit about hyperspectral. Would you mind joining us for a minute and just tell us about the hyperspectral, and do you think that has a role in actual perfusion assessment?
Sure, yes. I was an early adopter of the indocyanine green technology, but as everybody else mentioned here, there is a lot of pitfalls with it, and most of it was cost related. With these newer hyperspectral imaging devices, a lot of it's investigational. We're currently running some protocols where we're looking to kind of correlate the images that we see with standard, SPP, ABI in our angiography. So far, there has been some preliminary evaluation that there is some syncing up of the data. I think the benefit is that it's a very easy tool to use, cost effective. Currently, and sadly, there's not a reimbursement code for it, which is something that these companies are working on. But I think there was a lot of things that were answered with the new technology of the device in terms of cost and the size of the device. It's a quick shot camera, quick snapshot camera, and it does provide an image very similar to what you were getting to the SPY. It doesn't go as deep as the depth is different, but we're really looking at tissue perfusion. So it's about a 3 to 5 millimeter depth. And we find there is some correlation. There's definitely more work to be done. There's about 4 imaging systems on the market currently, and we're evaluating all those and hope to have some information in the next 6 to 8 months.
Thank you. Is there a question at the back?
Hi, I just kind of wanted to readdress Dr. Carmen's speech, but towards our revascularization colleagues. What is it that you guys expect from us, your colleagues as podiatrists and wound care specialists? When should we be reaching out and contacting you guys during the care process?
I guess that's you and me, That's a great question, Morgan. I love that question. Honestly, I rely heavily. I'm not a wound expert. I know I've learned a little bit from people like Terry Carmen and Georgianne Botek and that I worked with in the past. But, so I understand a little bit of the lingo, but I heavily rely on the podiatrists and my colleagues, my wound experts. So my expectation is that, and I always say that your expertise and your clinical assessments supersede any ABI or TBI or any perfusion assessment. So I expect that, if you see the wound is not going in the right direction, that you pick up the phone, just like I should call you and let you know what I did, that you pick up the phone and tell me, hey, listen, I saw, and this doesn't happen, and sometimes it does happen, obviously. But, to let me know that you're not happy with the wound, what your concerns are, and those kind of things. So that's number one. And number two, honestly, I want to emphasize this, and I don't know if you're going to get a chance to do it later. So you guys are the gatekeepers for a lot of these patients. And I think you understanding the perfusion and the angiograms and what are the capabilities are critical in trying to get the patient to the right operator, whoever that is, a vascular surgeon or a radiologist or a cardiologist. So understanding what the techniques are, how much can be done, what the perfusion looks like, I think is critical. And the other thing that I enjoy is when you guys call me and ask me about the angiogram or about the ABI, about the result, you want to see pictures, I really enjoy that. And the best example of that is Dr. Carmen, because she doesn't even trust me. She goes and looks at it herself, and then she calls me.
I'd like to also elaborate on that. I think it's a very symbiotic relationship, and in our institution, we have a direct relationship with our revascularization colleagues. We have shared clinics, and I think that does help those patients to be more successful. They may not necessarily round on those patients on a frequent basis. They may do the revascularization, and it's kind of left up to us, the podiatry team, to kind of manage the wounds. And if I see something that looks suspicious, I'll pick up the phone and call our revascularization colleagues right away. And chances are something's changed in the vascular status, and I think that direct communication will lead that patient to being on the operating room table, usually within 12 to 24 hours for an evaluation to see if something's up.
Panelists, any questions?
Yeah, I have one question. Dr. Botek, you showed a couple of studies where they showed that patients that had bypass had better amputation-free survival compared to those that had endovascular. I have looked at actually those couple of studies, and I wanted to get your take on this issue of selection bias. Usually, folks that don't have targets, that have desert foot, that don't have any, bypass autologous vein, are the ones that end up with endo. And those that have a nice targets, have a good runoff, usually get the bypass. So how much do you think selection bias may be playing in that role? And also, that cohort doesn't include those no option patients that ended up with amputation, because if they got major amputation, they were excluded.
Yeah, I mean, I think there's probably several inherent questions about those studies, but they're still out there. You know, it's like we need something to counter that. So, I mean, I think there's a lot of variability. It could be technique, the technician, the patient population, the postoperative course, you know, because even their transmetatarsal amputation results were lower in success than you might expect for that procedure. So, you know, I question the results, but at the same time, they're there.
It's just hard to, and please comment, it's just hard to do this study because, like I said, if you try to do it retrospectively, you're going to have this selection bias. So the only way you really can answer this, in my mind, is prospective randomizing patients that qualify to both endo and surgery, and then seeing how they do. And this was done obviously in basal, that showed no difference in amputation-free survival or mortality, with significant morbidity and length of stay and cost towards surgery. I don't know, Tino, what do you?
I think what Dr. Botek is right on, and that's that we need more studies and we need better studies. And I mean, I think this is why best CLI is really important. Right. I think this is why basal 3 is important, and to get in the literature and really see in a randomized fashion. Because you're right, there's definitely selection bias. And I think if you had a patient that had the best anatomy, I would probably send them to surgery if I could too. But it's a selection, you know.
I also have a question for Dr. Botek. You had mentioned earlier that you do a lot of TCPO2s in your facility. Is that done by your department? And do those patients also have vascular studies that are done, the ABIs and the TBIs? I was curious if you noticed the discrepancy in the studies there, just alluding to the fact that we had heard earlier that the ABIs might be an overestimate, essentially, and that of what the actual circulation is. Do you feel that they're accurate in your diabetic patient population with the calcification of the vessels, in helping you determine if we're looking at a salvageable limb or if we're going to be able to get wound healing more?
I mean, I think Terry might be able to talk on this a little bit better than myself, but you know, it's selectively used. This is really only for our pre-ops, and I do have one of our cardiology interventionalists is doing more of them post-procedures for looking for objective criteria. So, you know, looking at pedal runoff somehow to determine ideal level of amputation. The nice thing about TCOPO2 is it can be kind of tailored and personalized. So we're directing those probes to right around the surgical site that we're looking at. So I feel like it's pretty accurate, but at the same time, you know, it's not like I have a lot of evidence to back that up. I just feel like at my institution, that's the best thing I have right now for these critically these CLI patients.
Have you noticed any discrepancies that you've got a TCPO2 on a patient and they've had an ABI or a TBI that's actually been, that appeared that the patient would have healed?
I think opposite. Like I've got them thinking they're not going to heal my amputation, so I get them to like, and then I'm proven wrong and I do the amputation.
Brian, what's your experience with the TCPO2?
No, we don't use much of it in our clinic. We rely on SPP as well as Doppler ultrasound. So in the past, in some of the other institutions I worked at, the TCPO2 was found to be too unreliable, so they just stopped utilizing it.
Raghu had to take an early flight, but I have a question. Maybe you guys can help me with this. You know, when you're worried about a mixed ulcer, like sometimes you don't know, especially if you're like someone like me. I'm not an expert. So my view of this has always been that, you know, there is something that causes the ulcer. So let's say it's edema, trauma, pressure, whatever it is. But I am interested in knowing that is there enough perfusion to heal the ulcer. So my view is that anytime a patient shows up with an ulcer, the ABI is so cheap and so easy to do, you know, doing an ABI, TBI, that I believe that every patient deserves, even if when you think you're 99% sure this is venous, it doesn't hurt to do an ABI with TBI just to get the assessment of perfusion. Do you guys agree with that, or do you think that's too extreme?
So I will tell you my practice. If I can feel pulses and I've got a good Doppler signal, and that includes a Doppler signal at the first and second web space, I would probably not go with it, get an ABI on everybody. But if I don't feel pulses, they've got other high risk factors, they're biphasic or even worse, monophasic, absolutely, I think you have to have an ABI because you have to know what your baseline is and you have to know where you're at. You also have to realize if they're really swollen, your ABI may not be completely accurate. So you do struggle with that, and there the TBI may be more helpful and things like that. But it really does depend on that first clinical assessment. And you know, when you're talking about something distal, I mean, when he was talking, these are true, you know, venous ulcers with a mixed arterial component, if you will. If you're talking about something over the foot and ankle, I think you also can start with what the ulcer looks like, right? If the ulcer looks bad, you know, the cat's out of the barn. You've got to do something a little differently. The venous ulcers, you've got a little bit more time, but I think I rely on that first clinical assessment.
I'm getting a TBI on every ulcer I see. It's just part of my protocol. I mean, I think the American Diabetes Association recommends non-invasive arterial tests on every diabetic patient at the age of 50, and then a diagnosis of type 2 within 5 years of type 1. So, I mean, I feel like we really underutilize those non-invasive tests. They give us some information, and it can't hurt, and it protects you.
Can I ask Dr. Pena, you get an ultrasound on everybody that you do an ABI on, and that's a really time-intensive, laborious test. I think my ultrasound techs will probably buck and kick if I start getting bilateral lower extremity arterial duplexes on every ABI, particularly in Dr. Shishibor's clinic, because I read on his vascular days, and I bet you I read 14 ABIs. All my techs are going to have carpal tunnel.
It is very difficult. I think over the last 6 months to a year, they've gone to trying to come up with this express. You know, they're not concerned about our patients because they know our patients have disease and it's important, and we use it, you know, to really, we didn't talk about that surveillance of the patients, but really their concern is in the ED patient where, you know, you're looking at a lot of patients that maybe it shouldn't be ordered. So we have come up with like an express, we call an express exam, which really involves, it doesn't include necessarily the entire Doppler map, an ABI, you know, PVR. If that looks good, they stop. But again, it's only in the ER. So I mean, if it's something that we order, that's what we do, and that's always been the issue, right? It's how labor intensive, and you know, we run our labs 24/7, and that's really a pressure. But we still think it's important. You know, if we have to repeat one, it's even worse. So, you know, we decided this is how we're going. But yeah, we get a lot of pushback.
Dr. Shishibor, do you like CTA and MRA before you see the patient, or would you rather see the patient first?
Yeah, you know, I am not as savvy, obviously, as Dr. Pena. He's an interventional radiologist, so he has skill sets that I unfortunately don't have. So I obviously cannot do very well with MR. CT I can read, not obviously as good as him, but I think I can figure out what I need to do. The challenge I have, as he mentioned earlier, I think MR, because a lot of our patients are CLI, as you know. So, and I'm interested in below the knee and the foot and those kind of things. And I just have I don't think CT does give you, I don't think CT gives you that kind of information for me to know if there is blood flow all the way to the toe, to the ulcer. And because of that, and a lot of our patients have CKD, and as you know, end-stage renal, well, if they're end-stage, it's not a big deal. But end-stage renal disease becomes a big deal because of calcium. So either it's end-stage renal disease because of calcium and calcific shadowing, or it is because of because they have CKD and I don't want to use dye. And honestly, I feel like I can get a very nice angiogram if I, you know, I'm in the old school of you need to bring your catheter close to the popliteal artery, take selective angiogram of the, you know, tibials and the foot, and you can really get a beautiful angiogram with about 5 to 6 cc's in 2 images, and really get a good understanding of what the blood flow is to the foot. So because of those reasons, I am much more selective. So I do rely on PVR, on multi-segment PVR. So what I do sometimes, you know, and I don't know if you like this approach, when in patients that have isolated below knee disease, I try to go antegrade. And in order to rule out any inflow disease, I rely on segmental PVR and a duplex ultrasound of the, you know, the proximal arteries. And if the iliacs and the common femoral proximal SFA is fine, then I know that, okay, I can go antegrade. And I just take an antegrade approach, and just, like I said, I use 5 to 10 cc's of dye and get an angiogram. So this is for CLI, distal disease, obviously.
Yeah, no, I think that's really one of the first areas, and that is, are you going to go antegrade or are you going to go up and over? And I think, the ultrasound, I mean, we use it in many situations where that's all we have, and we use that. And I agree with you. Do we have a triphasic common femoral artery? Look at that common femoral artery. How much plaque is in there and really what's going on. I mean, I think you're not going to puncture an occlusion, but at the same time, if it's pretty diseased, you don't want to puncture that. You may want to go up and over. So I think looking at it and making that determination is important. I think CT and MR helps me a little bit with that. And also, if you're just looking at the segmental pressures, I think you may miss a proximal SFA lesion that you may get in antegrade, and then you realize I can't treat my proximal SFA because I got through it. Again, subtleties, but I think, the ideal, you're right. I don't think we have the ideal test. If I can come up with an MRA that I can see those tibial vessels and show you what the foot anatomy is like before you go in, I think that's the bullet. And I think that'll help us plan. That'll help us say, look, on this particular patient, it is, we're learning more and more about pedal flow. It's not just the pedal plantar arch. So if you're able to see that and characterize that patient's circulation, you're already going in with a treatment plan. And if you're doing that, I think your procedures are better, safer, and I think that's what we need to get to.
What are your thoughts? Maybe I can follow up on that. What are your thoughts about bold imaging and perfusion, MR perfusion assessment to assess tissue perfusion? Do you think that has any room? Or?
I think there probably is a role for it. I mean, and even in some of the cases I was showing, you can see some of that blush. So there probably is a role for that. I've looked at it. We haven't been able to run with it yet. But I think there probably is a role with that, just like there is, with perfusion, with, an angio and this and that. How are we going to interpret it and what it means? It's a lot of questions.
One quick question to you fellows and Dr. Carmen. So if we have a specialist, then one of our patients sees a specialist and they say, well, they've got small vessel disease, non-compressible small vessel disease, there's nothing we can do about it. Is that a fallacy, or should we take them at that face value with that type of response?
So clarify that for me.
So, a patient of ours has a challenging problem, non-healing wound or critical limb ischemia, and the specialist says, well, there you have non-compressible small vessel disease, there's nothing we can do.
But what does that mean? That means on angio they don't see anything, or that means on ABI they have non-compressible ankle vessels with evidence of metatarsal and toe pressures that are compromised?
Sometimes we have the workup and sometimes we don't. But I mean, assume that the full workup's been done.
It's not unusual, to be honest with you, Georgianne, and this is one of my pet peeves. That's why I'm so glad that all these folks are here, to be honest with you, because, Terry, what happens, I mean, obviously, I think you're very, you're a master and you're very aggressive because you look at the angios, you look at those things. Many folks in the audience, like many of the podiatrists I even work with in the community, they don't see my angios. I can tell them whatever the heck I want. And I am never going to, I don't think I would call him and say, I suck, I don't know how to open those arteries. So I probably would make something up. Oh, it'd probably be okay. They are calcified. I mean, I think that's where Georgianne is going, I think, to some degree. And my point is that in this day and age, is really, I'd be interested in what you think. I think you got to be very careful when people are telling you small vessel disease, because that's a misnomer. A small vessel disease, are we talking about tibials? Are we talking about digitals? Are we talking about the pedal arch? So I think you have, like Dr. Carmen is asking, you really need to ask questions like, what do you mean by small vessel disease? When you say heavily calcified, no option, what do you mean by no option? Do you mean there is, everything is perfect to the toe or to the ankle, or that you just fix the SFA and the tibials are too calcified and you're not going to fix them? And that's going to become an issue for most podiatrists, because if the perfusion is not optimized and you go ahead and do a minor amputation, well, those are not going to heal. And guess what? The patient is going to say, well, I went to the vascular operator, to the vascular guy. He told me everything is fine. I come to you, you did my amputation and it failed. And now you want to do more proximal amputation. So I do think that as podiatrists, you need to be very versed and ask the exact same, I mean, I love that what happened just here. Ask these kind of questions and say, what do you mean by, small vessel disease? What are you talking about? Are you talking about in the foot, in the tibials, and those kind of questions? Do you know?
Yeah, I mean, I think Dr. Beckman would be great to ask when he comes tomorrow for the next session, because he just published an article this month looking at microvascular, what they call microvascular disease, and showing the results in patients. But there is a population of people that feel that there's certain patients that no matter what you do, that distal capillary is to a point that it's not going to get better. How you are able to identify these patients, I don't know. But I know that that's some people are trying to say, can we identify the patients that we can't save, and can we identify them earlier? Is that microvascular disease, or is that some other form? But something like that. Again, I'm like Mehdi. We go to vascularize. We try to open as much as we can, even if we can get an artery right to it, and go and But usually, if we get inline flow, it's not going to be a vascular issue, right?
In these no-option patients, just looking for a consensus, what are your thoughts on deep vein arterialization? This has become something that's being done more popular and more frequently in our institution with some varied results. Now, the flip side of that, the podiatric procedures have to be much more radical. But what are your overall thoughts of that?
Brian, I think that is, we're learning. I mean, I think you're in your operators that you have there are pretty much at the cutting edge of that. But learning as to when to do it on those patients, how to manage those patients after that procedure, like you said, without a doubt, it's helped the certain patients when you're able to do it at the right time and get the kind of technical results that you want to get. So I think it's an option. It's just another tool that we have for these patients with desert foot. And I think, at least personally, what I'm trying to do is I'm trying to learn when to do it, which patients to do it, and how quickly to do it. And that's still where I'm at in my process.
I mean, I would say the one thing I would just add quickly, is that probably all of our patients with diabetes have microvascular disease. I mean, if you have macrovascular, how are you not going to have microvascular? I mean, the point I was trying to make is just understanding what did that mean when they say microvascular, because that sometimes can be variable in my own experience. And then the other thing I think is that this communication is very important, because in those with significant microvascular disease, some of these other modalities may be helpful, such as hyperbaric oxygen, arterial flow pump, and those kind of things. And again, the communication comes into the picture, because if I can communicate that and my success to my colleagues that do the wound care, maybe they'd be more aggressive with some of these adjunctive modalities.
Yeah, I think that was my point, Georgiana, I'm not sure what it means.
Right.
All right. We are a little bit over. I appreciate everybody keeping their attention and staying a little bit late. Thank you, and we'll see everybody tomorrow.
Yeah, exactly.